I have nothing to disclose. And, sorry. So we don't have the time today to be comprehensive, so I'm going to focus on 3 main implementation issues. And I'm going to provide you with the punchline straight off. My argument is that we have largely failed children with HIV. I know that's a strong statement, but I'm hoping to show you how we can hopefully do better. By the end of this talk, I hope I've convinced you that first, that we have largely failed to find children and link them to care, emphasizing and operationalizing mother-infant linkage can improve case finding. Second, that effective and palatable treatment options are urgently needed for better treatment outcomes. And finally, third, for adolescents who unfortunately are being failed in multiple ways, prioritizing switching to better ART regimens can be a quick win. So let's start with case finding. Earlier today, we heard how even though numbers of new infections are going down, we've had almost 6 million infections since 2000 with over 4 million deaths. Now, those are heartbreaking, almost inconceivable numbers, and they speak to our failure to effectively find and link children to care. This graph shows where we are today. Let me see, just figure that out. And you can see that we still have a very significant treatment gap with roughly 750,000 children with HIV needing to be identified and linked to care. So this slide shows that not only is the treatment gap for children large, but it is much greater for children than for their mothers. So the children are in gray and their mothers are in orange here. To bring kids up to the coverage level of their mothers, we would need to improve coverage by about 50%. And I want to focus in on this, draw attention to this. Why is the treatment gap for children so much greater than that for their mothers? So the first obvious reason is that early infant diagnosis testing rates are improving, but they're still low, with global coverage around 50%. And once children are missed by EID, it's a challenge to find them. Some of you may be questioning that. Why is it such a challenge? A number of studies would suggest that case finding shouldn't be this hard. A systematic review and meta-analysis by Cohn and colleagues from 2016 showed very high prevalence of HIV in inpatient nutrition and even outpatient and immunization clinics. In Malawi, where overall prevalence is much less than in countries like Eswatini or Lesotho, papers on pediatric HIV testing have also shown very high prevalence. However, our program data from last year as an implementer paints a very different picture. In these same settings where we as a program have achieved over 90% coverage, we have much lower prevalence and even lower yields. So to understand this a bit better and to help guide our strategy for case finding, we conducted an exercise using data from Spectrum to estimate expected yield based on testing approach. Now, this is a very busy and comprehensive slide, so I'll take you through one line to help you understand what we did. Sorry. This is the case for Malawi. To generate the numerator, Spectrum provides the total number of children with HIV as well as the number estimated to be on ART. Subtracting the first by the second gives us the number of children HIV infected who are not on ART. These are the kids that we want to find. For the denominator, Spectrum provides the population less than 15, very straightforward. For our HIV-exposed children, we use the mothers needing PMTCT over the last 15 years with a small adjustment for miscarriages and infant-child mortality. What this provides are some benchmarks. In Malawi, if we were going to take a general population testing approach, say a community campaign, we might expect a yield of around 0.5%. If we were going to take a more targeted approach in which we focus on only testing HIV-exposed children, say some sort of index case finding, we may expect a yield of around 4 to 5%. Now, there's some limitations to this. HIV-infected children aren't distributed uniformly through age bands, but this gives us a general benchmark, which I will refer back to. So, going back, in this slide, I focused on the outputs of this exercise. And what you can see is that for almost all the high-burden countries that we looked at, a general population testing approach will give you a yield less than 1%, an expected yield less than 1%. And even with an HIV-exposed restricted testing approach, your yield will be somewhere in the 2 to 5% range. So the take-home point here is that it's hard. Even with an approach targeted on HIV-exposed kids, you need to do a lot of tests to find one case. So this provides us with some benchmark, some baseline of what reasonable expectations should be for our case-finding efforts. So given these challenges, how do we find the kids? I'm going to suggest that there's a potential approach that can dramatically improve pediatric treatment coverage, does not require significant additional resources, but has yet to be implemented fully. I'm going to refer to this as optimizing mother-child linkage, but let me explain a little bit more first. This is an important chart from the Department of HIV/AIDS in Malawi. I could talk about this graph all day. I really love it, but I'm going to focus in on a few points. First, what you notice is that we have very detailed information about ART status in pregnancy. In blue, what you have here are mothers who are initiating ART when becoming pregnant or breastfeeding. And what you have in orange are women who are already on ART when they become pregnant. And we have this information not just at the national level, we have it at the district level, we have it at the site level. Second, if you counted these blue bars and added them up, it would total to about 250,000 women. That represents 2/3 of the ART cohort for women in Malawi. So we have very detailed information about the mothers, but very little information about what then happened to their infants. And I'm going to show you now why that is and how we might change that to improve case finding for infants and children. So this is the adult ART MasterCard in Malawi, and it's an excellent clinical and data collection tool. It's very compact, but it's high impact. It's designed to both lead the clinician through their visit, as well as help the clinic and health system collect essential data. And what you can see here, hopefully, is that right after the clinician weighs the patient, right at the beginning of the visit, he or she confirms if the patient is pregnant or breastfeeding. They ask every adult patient this question, well, every adult woman this question. It's literally the second question they ask. Now, you would think that the next question would logically be about the children. Are you pregnant? Are you breastfeeding? Do you have a child? Have they been tested? But that's not what happens. Rather, it jumps immediately to TB status. The status of the child is omitted. So this omission also pertains to supervision. So in Malawi, there's a quarterly supervision exercise in which every site is visited and their records are checked. And the supervisors have a checklist in which they confirm that the clinician, among other things, is filling that MasterCard out correctly. To be a clinical site of excellence, which is valued, you have to get all these answers right. And again, reflecting the MasterCard, infant testing is not a field that is checked. Now, what does this mean practically? So what we have here is an important example. I hope you can see it. This card is a microcosm of the EID system writ large with all of the same issues. What you can see is that this mother has gone from pregnant to breastfeeding. So the clinician has recognized that a child has arrived. The mother is clinically stable and she's judged to be adherent, so she also has her ART visits spaced. And the clinic where the service is delivered has passed its supervision. But no infant information has been collected, and this child has not been tested. So you might be asking yourself, fine, what's a better system? So this is the LESOTHO version of the patient MasterCard, the same sort of data collection tool. And what you can see in the lower left corner over here is a family tree, which I've blown up over here. Now, this is a really good start, but it could be even better with a few small tweaks. Sorry, let me show you those. So you can have a box. This is what I would do. You can have a box. I don't know why the box is missing, and a date that indicates that the family tree is complete. You've completed it. And then you can put totals on the bottom to show how many family members there are, how many kids there are, and what their HIV status is. With these small tweaks, you create a system that can be monitored very easily, You can have a complete assessment of how many women have been checked, how many children they have, and what their status is. And even in a site with 1,000 women in care, you could monitor and tabulate these results in an hour or two. And I know because I've done it. So that could make a lot of difference and make a big improvement in terms of linkage. Now, there are a number of pilot programs implemented in various countries that have utilized mother-infant linkage to improve testing rates and case identification. These different programs are unique in implementation, but they all showed impressive yield as well as very high acceptability from caregivers, which is equally important. I don't have the time to break all of them down, so let me just talk you through the example I'm most familiar with. So this is for our Malawi Tingathe index case finding pilot, and in this pilot, every ART patient was a potential index, which gave us a very solid denominator. Within 6 months, we were able to screen 65% of the ART patients and 94% consented to testing. 279 reported an untested child. 711 children were tested, giving us a 4% yield. So moving forward, we're focusing this process more on mothers. We're asking if there's a difference when asking about the whole family versus just asking about the children. And we're working with the Ministry of Health on looking at return visits and potentially delaying multi-month prescriptions until these are complete. So some of you may be saying, hold on a sec. Most countries have policies. They're doing index case finding. Saeed, what are you talking about? And indeed, that's partly true. Katie Simon did a review of national family index guidelines and tools, and all the countries she looked at had language endorsing family index testing. But there are a few issues here. First, practical, efficient tools are needed. It doesn't have to be an EMR. The paper records I showed you earlier work just fine, but it needs to make that linkage explicit. Second, index case finding or mother-child linkage should capitalize on the opportunity of repeat ART visits. This is something that's overlooked frequently. Mothers are coming. Are we utilizing that opportunity when they're showing up for their ART visits? Third, multi-month prescribing should perhaps be held or suspended until this process is complete. It incentivizes the mother and families to get this done. And fourth, it needs to be part of the national ART supervision. We've seen that mother's ART data is very good. We need to track and report on this child testing data alongside that. Now, this is not going to bring case identification to 100%, but it should equalize mothers and their children, which would be huge. With this infrastructure in place, joint mother-child interventions for case finding, adherence, and retention are possible. And then you can focus your more intensive efforts on orphans, late incident infections, and other outliers. So hopefully I've convinced you that improving mother-infant linkage provides a framework for improving case finding. In addition to this, there are several developing strategies that I want to mention. So let's start with point-of-care early infant diagnosis. 3 studies have been published on point-of-care, and all of them showed very impressive improvements in results return and ART initiations. Now, these are powerful results meriting additional investigation and investment. However, these studies also show that you need a functional cascade of care. They don't solve the problem in of themselves. In both Malawi and Mozambique, you still had infants testing late, and in Mozambique, there were very high rates of loss to follow-up for infants starting ART. We have not started birth or very early testing in Malawi, so I don't have any hands-on experience with this. We all see the potential benefits of early initiation, but we are waiting to see if the significant technical and programmatic challenges can be addressed. Screening tools. They've been getting a lot of attention, and we have started trialing them in our own program in Malawi. Studies have demonstrated that they do decrease the number of tests you need to do to find one positive. However, as implementers, we have a number of concerns, including sensitivity, relatively high baseline yields when you don't use the screening tool, and questions about what population these tools might be most appropriate for. Now, there are no studies that I'm aware of looking at screening tools in under 5 or immunization clinics. where you can imagine they would be very useful because of the overwhelming volume that are coming to those sites. So there is another strategy that might help quite a bit with overwhelming testing volumes, and that's oral testing. The OraQuick saliva-based test has not yet been WHO pre-qualified. However, validation studies have shown very good sensitivity and specificity. The CDC is studying acceptability, feasibility, and impact of HIV screening with caregivers administering the test. Put simply, by removing the need for a healthcare worker, this can be a real potential game changer for addressing high testing volumes and hard-to-reach children. So lastly, I want to make a quick note about community campaigns. A number of implementers have suggested community or school-based campaigns might be a way to mop up children with HIV who have been lost to care, but there have been few practical examples. Well, the search trial in Uganda and Kenya managed to test 82% of children aged 2 to 9 years in 32 communities. They did an astounding 72,000 tests in this age group. How they got that by PEPFAR, I don't know, but they did show that mass testing of children is doable. Of that 72,000, 817 were HIV infected, so about 1%. The yield by category is very illuminating, though. What you can see is that the majority of HIV-infected children, 756 out of this 817, or 93%, were found with either HIV-infected or HIV-unknown mothers, confirming the idea that the money is with the mothers. If you focus on linking the mothers, you'll find the children. So let's move to care and treatment. This slide here shows one of the major issues, one of the major challenges facing the treatment of children with HIV in Malawi. What you can see is that compared to adults who have viral suppression rates in the 90s, of the children we have managed to link to treatment, roughly half are unsuppressed, with suppression rates in the 40s in the very young infants and in the mid-60s for the older children. And this is not unique to Malawi. As Sizue demonstrated earlier today, this is a challenge across the region and has been demonstrated again and again and again in high-burden countries. So why are viral suppression rates so low? Many are placing the lion's share of the blame squarely on Nevirapine. Many of you may know, in Malawi, as in other countries, over 90% of children are still on Nevirapine-based regimens. This is problematic, as the P1060 study showed superior efficacy of lopinavir-ritonavir, and other studies have shown high rates of drug resistance to NNRTIs. Initially, this was a logistical dilemma, but with the availability of pellets, countries, including Malawi, have committed to fully transition to lopinavir-ritonavir, with PEPFAR going even further, and mandating that countries completely phase Nevirapine out. Now, but will this solve the issue? So lopinavir-ritonavir pellets, are they the answer? Our experience at Baylor suggests that they might not be. In multi-country pilots looking at the pellets in children under 3, we have had poor viral suppression with the pellets. In Swaziland, 21 children were trialed on the pellets, not one of them suppressed, and 81% of the caregivers there preferred syrup. In Lesotho, they had better viral suppression rates, but it was very poorly tolerated in the under 3s, and they've decided to continue syrup for that age group. In Malawi, we conducted our pilot at outreach sites, and of 63 children, 41 did not suppress, so 35% suppression rate. Now, I need to say that, I think if you are not a clinician and are not familiar with, have not seen what it looks like to give the pellets, it is good. There are some videos on this. I was going to show them, but I don't think we have time for that. For now, for us, suffice to say, caregivers and providers at our clinics are really struggling. Other groups have had different experiences with the pellets. In Zimbabwe, a study showed that 89% of parents assessed their child's response to the pellets as good or very good, despite 50% reporting some challenges with it. The Living study, which is evaluating the effectiveness, safety, and acceptability of pellets in Kenya and Uganda, will likely provide us with much more information. So after our pellet pilot results, we conducted an audit at our main center of excellence to look at how our kids were doing overall. And here the results are a bit more reassuring, with overall suppression rates close to 90% in our Nevirapine group and 72% in the Kaletra group, with many receiving Kaletra as second line. It's important to keep in mind that to achieve these results, we have counselors, we have nutritionists, and physicians providing support. But even here, we are struggling with the very youngest kids. So hope is on the horizon, though. Martina earlier talked about what is coming down the pipeline. Raltegravir, lopinavir, ritonavir granules, and dolutegravir show great promise for improved treatment outcomes in children. In the meantime, some more advocacy and media attention is needed to hold our feet to the fire. I rarely hear about this issue. In Malawi, if there are a few cases of gynecomastia or erectile dysfunction in men, you hear about it in the press. But these challenges for kids don't make the news. I've yet to see a Keep the Promise protest for children, and I think it would help to make sure we receive supply chain support to maintain adequate global supply of key pediatric drugs, as well as to make sure there's dedicated funding for peds. At Baylor, we've always taken the approach that if you can treat adults, you can treat children, and we still think that's true, but obviously some additional support is needed. This is not easy even for providers who are experienced and have resources. So finally, and this might be slightly contentious, until better options are available, countries should probably keep Nevirapine available as a last choice option for children who cannot tolerate or access lopinavir, ritonavir, cannot take efavirenz, and do not have access to raltegravir. So let's shift attention to adolescents for a bit. As many of you know, adolescents face a myriad of issues, including stigma, disclosure, transition, retention, and care. But I want to focus on an implementation issue, namely failure to switch off failing regimens. A number of studies have shown how many adolescents with high viral load are not switched, with adherence often blamed and true treatment failure not recognized. A study from Uganda showed how adolescents are often caught in EAC, or intensive adherence counseling cycles. Essentially what happens is they are recognized to have a high viral load, but need to have completed 3 counseling sessions and get a repeat viral load before a switch is made. And this study showed that this can take a very long time. The whole time they're failing. And then even when failure is confirmed, as shown by the IDEA study, many are still not switched. So our colleagues from MSF in Chiradzulu, Malawi have provided some helpful data for us to think about this. They have a large cohort of almost 2,000 adolescents. Of these, they took a convenient sample of 405. Median age at ART initiation was 7 years for this group, and the median years on ART was also 7 years. 85% of their adolescents are on AZT3/TC Nevirapine. So in this group, they did a cross-sectional assessment of viral load and genotyping, as well as some measures of drug concentration to assess adherence. And what they found was that 1/3 of their adolescents were not suppressed, as compared to only 12% in the general population. Of those not suppressed, 84% had resistance, and this resistance was present despite good measures of adherence. After 3 months of adherence counseling, 97% were judged to be fully adherent, but only 9% went on to resuppress. The bottom line we took from this is that adolescents, they need to be switched. Within our Tingathe program in Malawi, we have shown that both adherence counseling, delivery, and switch can be improved with consistent messaging and supervision. Following a very simple intervention of education where we were basically just alerting clinicians to the importance of switching, we saw a significant improvement in teens completing their adherence counseling, as well as appropriate switches being made. It was a super simple intervention, but had big impact for those adolescents. So one of the reasons I'm emphasizing this issue of switch is that with the rollout of dolutegravir, this is a golden opportunity to get adolescents on effective regimens. Dolutegravir is highly potent with a higher barrier to resistance, once daily dosing, and lower rates of treatment-related side effects. In Malawi, TLD for kids over 30 and dolutegravir with daily abacavir 3TC for kids 20 to 30 kilos will provide a 2-drug switch, as most adolescents are currently on AZT 3TC Nevirapine. So waiting on viral load does not need to be a barrier to this transition, which is really important for this to happen in an expedited manner. Obviously, continued support to accessible sexual and reproductive health services is critical and a big topic in of itself. So hopefully I've convinced you that though we have been failing children in a number of ways, we can and should do better. These are the 3 take-home points I hope you will go home with. For finding kids, emphasizing and operationalizing mother-infant linkage can dramatically improve case finding. For care and treatment, effective and palatable treatment options are urgently needed for better treatment outcomes. And finally, for adolescents, prioritizing switching to better ART regimens can be a quick win. I'd like to thank the Malawi Department of HIV/AIDS, my colleagues at Baylor, USAID and PEPFAR for their support, UNAIDS, and my presentation team. Thanks very much.